right, y'all, 6 o'clock, we can kick it off. Thank you for joining. We are very lucky to have Dr. Jared Woodward today, who is one of our wonderful neurologists. But I will let him introduce himself and kind of kick off the topic. So it's all yours.
Great, thank you. And thank you for having me. I really appreciate the opportunity to talk to a big group of individuals on a topic that I feel pretty passionate about. My name is Jared Woodward. I'm a neurologist and a psychiatrist. I work at CU Anschutz. I work primarily in the epilepsy division, seeing adult epilepsy patients. But I also have some grant support to see patients with this disorder we're going to talk about today. And we have a program here that treats people with what's called functional neurological disorder. I'll be talking about one of the more common subtypes of functional neurological disorder, which are called functional or dissociative seizures. So thanks again for having me. We're going to kick things off with a clinical case. This is a case of a 35-year-old male. He has a past medical history of epilepsy, and he has a known left hemispheric parenchymal hemorrhage, which is the source of his seizures. He's been kind of challenging to control on medications. He does have a vagal nerve stimulator device that's placed, as well as he is on anti-seizure medications. To complicate matters, he's also been diagnosed with documented non-epileptic or functional seizures. So he has both conditions. He also has a Chiari malformation. He underwent a suboccipital decompression, migraines, also has PTSD. But EMS was called to evaluate this gentleman due to a prolonged convulsive seizure that he was experiencing at a dentist's office. En route, EMS received a report that the dental staff had given the gentleman a mild benzo for a routine tooth extraction, and then he began to have a seizure. So upon presentation, this is what the patient appeared like.
We don't know. Can I have to make a video of it because his doctor wants to do an EEG. Yeah.
Can everybody hear the sound?
Yes.
Okay, perfect.
Is the other a doctor? That's fine. Okay. Don't worry, I have your body, but I read it. It's fine. We're trying to get him to get another EEG so we can try to figure out what is going on, but his doctor told us not to call.
They're on their way. Yeah. Maybe we can have someone stand out that door to direct EMS when they get here.
Yeah, I'll do that.
Thank you.
Thank you.
There's going to be a dean at the front waiting.
Okay. It goes on from there, but you sort of get the gist. So this man is seated in the chair. He's having what appears to be a seizure. They're talking with the dental staff. There is a supportive person there who's taking a video per a lot of times physician's instruction to get a video of the event so we can get a better look at it. And then we do, of course, have permission to share this video from the patient himself. And so, upon encountering somebody in this state, of course, we're going to be running some sort of triage up front. So as a first responder, I think the questions that you would be probably asking yourself is, okay, is this person seizing? What's going on? Why might this person be seizing? But I would propose, more importantly, a question that you should be asking yourself is this seizure epileptic or not? Could it be something different? And if that's the case, how can we tell the difference? What should we do next? And what are the potential implications of getting it wrong, of undertreating, of overtreating? What could happen in this case? And so I think this clinical case is going to be very demonstrating of the potential outcomes. But before we get into what happened to this man, I'd like to just kind of quickly review what probably everybody on this call is very familiar with, which are some of the seizure protocols for EMS. And so the Denver Metro EMS, from my experience giving these lectures, is that it's kind of what the state kind of draws off of for establishing protocols. I think regionally there are some minor variations, but more than likely this is something similar to what you all are using in the field. So protocol 4040 says that we should follow this diagram. And so it starts with, of course, supporting the person's airway, making sure they're breathing, giving oxygen if needed, and then is quickly prompting the first responder to think about what could be going on. So is this hypoglycemia? Is there something that we could quickly reverse? And then, of course, seizure protocol. So when up here, I have a little box around consider the cause, which brings us down to the bottom of the flow sheet of all the different possibilities that Denver Metro lists as a cause for seizure. You see epilepsy, you see withdrawal from or intoxication, you see hypoglycemia, some sort of trauma, eclampsia for a pregnant woman, infections, febrile seizures for younger individuals. But nowhere on there is a mention of the condition that we're talking about today. So the possibility that the seizure could be non-epileptic. If the patient is seizing, then we are, supposed to follow a protocol. If it's brief and self-limited, no big deal. We just support the person, help reorient them, and hopefully they don't need to be transported to the hospital in most cases. However, if there are some reversible causes, we can potentially intervene. But if the seizure is prolonged for more than 5 minutes, well, technically that classifies us for status epilepticus, which is a medical emergency, in which case we follow guidelines that say that we should give 1 or 2 rounds of benzodiazepines spaced out between 5 minutes while we're transporting this individual.
Hot.
While we're transporting this individual to an acute care facility. Once they arrive, oftentimes they're loaded with anti-seizure medications and intubated if needed for airway protection. However, if the patient is not seizing or the seizure has self-resolved, it's more about just making sure that other medical conditions are addressed, doing a head-to-toe assessment, and hopefully establishing that the patient is okay. It also tells us that we should be documenting what we see. So the patient's seizure history, the onset, the time, any previous seizures, type of seizure, which all kind of comes into play with what I'm going to suggest here. So what I would add to this, and we'll go through this again at the end, is that how come functional seizure or non-epileptic seizure is not in the consider the source box? I think that might need to be there. And so my recommendation that we'll go through is that I think this should be one of the things that we're considering in the field. However, I know that can be potentially contentious when we're thinking about, as I mentioned, the outcomes of possibly undertreating or overtreating, but potentially undertreating something like status epilepticus, I think makes people nervous. But hopefully after this talk, you'll feel less nervous about that. So let's get back to our case. So en route to the ED, the patient had been seizing now for approximately 50 minutes. So if this is an epileptic seizure, this is a medical emergency. EMS gave the patient 5 milligrams of Versed times 2. 10 milligrams is standard of care per Rampart trial. 2 milligrams of IV Versed as well after IV access was established. He had an NPA in place, vital signs were stable. However, and the patient was withdrawing to pain, which is sort of interesting. Also had pupils that were reactive and no signs of trauma. So moving forward, and again, this is a real case, came to our hospital, patient actively seizing for 50 minutes. Concerning for benzorefractory status epilepticus. Overall, the patient received a total of 16 milligrams of Versed pre-hospital, and then in the ED got another 12 milligrams of IV Ativan. Due to ongoing seizure-like activity and poor airway protection, he was ultimately intubated and sent to the medical ICU. He had basic labs, had a head CT that was ordered, which is here pictured on the right side of my screen, showing an old area of encephalomalacia in the inferior portion of the left temporal lobe, which is thought to be the cause of his focal epilepsy, but there was nothing acute, no acute blood, no new signs of trauma. The patient was admitted to the medical ICU, had continuous EEG monitoring in place, which was negative for seizures. However, the patient was now intubated and sedated on medications, so not really of great diagnostic value. The sedation was ultimately weaned. He was extubated, transferred to the neurology service. And it was sort of only then that the team went through his history and said, oh man, this patient also has non-epileptic seizures. I wonder if that could have been what was going on. He was ultimately discharged within 24 hours back to his house and was told to continue his anti-seizure medicines and continue to follow up with neurology. So quite the whirlwind for this gentleman who went in for a tooth extraction, ended up in the ICU only to be discharged within 24 hours, where some real harm could have been done, is what I would say. So could this have gone a little bit differently? Could this patient's hospitalization been prevented? Could the first responders have acted differently? ED acted differently? If so, how? We're not pointing the finger at anyone, but trying to make sure things like this don't happen where they do, unfortunately, happen quite commonly. And is it reasonable for me to be sitting here and asking first responders, EMS, or whoever in the field to be considering functional or dissociative seizures as a cause in the first place? So that's what we'll be talking about today. If I was to give a quick broad overview of when we're potentially assessing a patient who has something that looks like a seizure, we generally put it into two different categories. There's epileptic seizures and there's non-epileptic seizures. I'll start with epileptic seizures because I think that's what people are a bit more familiar with. Broadly,
I'm so sorry.
yes.
Can I quickly interrupt with a question from the chat on the specific case before you go into the education?
Sure, yeah.
There's a question from Eden who says, do you think the airway protection or the lack thereof was more so a result of the functional seizure or from the amount of benzos the patient was given?
I can say with about 99% certainty that it was due to the amount of medication that he received. We typically don't see poor airway protection in someone who's having a non-epileptic seizure, as demonstrated by this case, and we will get into it later, so it was a good question. But, this gentleman's seizing for 45 to 50 minutes, and then when you think about back to the video, he had very good perfusion of his skin. There was no sign of cyanosis or oral trauma, and so very different than what someone with an epileptic convulsion going on for 45, 50 minutes would look like. Those people typically would not be protecting their airway. However, non-epileptic seizure patients will not stop breathing forever. And so I think sort of definitely this was due to iatrogenic causes from the medication he received. Awesome question. So getting back to sources of seizures, if it's an epileptic seizure, we broadly sort of separate into, is it focal, like in this case, or it was coming from one specific spot due to a lesion, or could it be generalized? Generalized seizures typically are either due to generalized epilepsy or primary epilepsy, metabolic causes, or withdrawal, whereas focal seizures tend to come from a known lesion or causes of focal epilepsy. However, there are other things that look like seizures that are not, and I would break those into two additional categories. There would be other physiologic causes of things that look like seizures, like syncope, movement disorders, things that make people twitch or shake or lose consciousness that aren't necessarily related to epilepsy. And then there's also a category of what we call functional or non-epileptic. So functional sources tend to me be more related to what we would think of as classically a psychogenic source. So something in the way that the patient's brain is processing information that's manifesting physically. And so today we'll be talking about the functional seizures. So to understand what a functional seizure is, you have to first understand the broader diagnostic category of functional neurological disorder. So this actually lives in the Diagnostics and Statistics Manual, which is the psychiatric Bible of diagnoses, which defines FND as one or more symptoms that affects your body or your movement or your senses. So very broad. So pretty much a neurological complaint. There has to be then clinical evidence of incompatibility between that symptom and another recognized medical or neurological condition. So what we mean by that is like somebody with a tremor that could be related to Parkinson's disease or essential tremor may look and behave and present very differently to an evaluating clinician. There's some variability in the way that the tremor moves. It might start and stop. It might get worse when the person is stressed, which is different than what we would see in something like Parkinson's or essential tremor. And then seizures, as we'll review today, convulsions related to epilepsy actually look and behave differently than they do in a functional seizure. So that's the clinical incompatibility or sort of like inconsistency, I would say. The symptoms cannot be explained by another neurological, medical, or mental health condition, and it should cause the patient impairment, as all disorders do. Of note, this is an updated definition from prior DSMs, where they used to require that there was always a psychological stressor that happened right before the patient had a seizure. And if that stressor was absent, it couldn't be functional. That no longer exists, as we know that patients with FND have seizures that are sort of out of their control and happen at random times. We will talk about, well, I'm not going to go into the details, but this goes by a lot of names, probably names that you all have heard differently. This used to be called conversion disorder. It used to be called hysteria way back when. Pseudo seizures caught on in sort of like the 1990s. Non-epileptic seizures, psychogenic non-epileptic seizures, or PNES or NES. But more or less these days, we're using this term functional neurological disorder. And then if we're going to define that more granularly, we would call this a functional or a dissociative seizure. So unfortunately, it goes by so many names, which I think is confusing. We're trying to make sure that we're using consistent terminology, but that's been a challenge just to how quickly the names have been changing over the last couple decades. And then finally, FND is different than non-volitional types of neurological complaints, which would be something like malingering or factitious disorder. In malingering, a person is simulating symptoms for a primary gain of like getting out of work or getting out of jail, something that's motivating them to be sick. And then in factitious disorder, also known as Munchausen syndrome, that's when patients sort of feign illness to obtain a sort of subconscious need to assume the role of a patient. So being sick to sort of get support from family or things like that, but are doing it on purpose. But this functional neurological disorder is different in that the people are not doing these on purpose. They are involuntary, which distinguishes it from the other conditions. How common are functional seizures? Well, it's kind of all over the map, as you can see by the prevalence. The most recent review we have from 2024 says the prevalence is somewhere between 24 to 2,000 per 100,000 people, which is a shocking number and a huge range, but it's just people don't code this disorder. Normally like how they should be coding the disorder as a functional seizure. It gets coded in ERs or in doctors' offices as convulsions unspecified, pseudo seizure, shaking. And so it's really kind of hard to pin down exactly how many people have this condition, but it is quite common. It does primarily affect females with about a 70-30 split. However, it clearly affects males as well, as we saw in this case. In adults, the age range is somewhere between 25 to 45. However, it does affect the young and the old. And confusingly, for some people, about 15% of patients with epilepsy will also develop functional seizures, and so they can co-occur in a single patient. So what's the scope of the problem? Well, functional neurological disorder, by some estimates coming out of the UK, said it might be the second most common reason why somebody sees a neurologist. So functional neurological disorder of some type. But functional seizures account for about 25 to 30% of all new patient referrals to tertiary care epilepsy centers like our university. When we bring somebody into the epilepsy monitoring unit to characterize what kind of seizures they are, about 25 to 35% end up leaving with a diagnosis of non-epileptic seizures. And this is a worldwide phenomenon, not just in Colorado. So the numbers out there are probably quite high, but under-evaluated. Treatment in ICU or acute care settings is comparable between functional seizures and epilepsy, with maybe even a higher incidence of people in ICU cares who have functional seizures. My rationale behind that is probably because functional seizures tend to be longer. They tend to they happen more in public spaces. And so more like acute treatment is common. Anti-seizure medications is also unfortunately high. It takes patients about 6 to 9 years to typically get a diagnosis of functional seizures because they end up in this sort of vicious cycle of going in and out of hospitals, new doctors, diagnosis of epilepsy, take that away, start a medicine, take that away, before they actually get the proper diagnosis. And so during that time, patients will at least be taking one anti-seizure medication per statistical reports. And it's also very expensive to take care of. So there was one study looking between 2019 and 2020, just looking at functional neurological disorders in ERs and inpatient settings alone for adults and children, that exceeded $1.2 billion just in the US. So it's an expensive condition to take care of. It's highly prevalent, and risk of iatrogenic harm is high. So kind of playing off of that motif, morbidity and mortality is unfortunately high in this population as well. We do see about 50 to 100% of patients have an additional psychiatric comorbidity like anxiety, depression, or PTSD. As I mentioned, harm can be done in acute care settings. These patients are disabled by this disorder as well, with lower rates of driving, higher rates of being absent from work or being on disability. And even one study out of Australia that says that people with functional disorders die more frequently than the general population. We don't know exactly why that is, but they tend to be an ill population with not just this disorder, but a lot of other serious medical comorbidities. In terms of what causes this disorder, what everybody's thinking, like, okay, well, if they're not faking it and it's real, but it's involuntary, I don't understand. Not a lot of people do. And so this graphic here with all these squiggly lines sort of proves that point in the sense that we've been trying to pin this down through neurological imaging studies, functional connectivity studies, and have sort of landed on the sense that we don't exactly know what's causing this. However, there does appear to be aberrant connections in people's brains who develop this disorder. One of the leading theories is that patients are exposed to higher rates of traumas, psychological traumas, physical traumas earlier in life that maybe alters connectivity in areas of the brain that are important for emotional processing. And sort of the point of this graphic here is showing a lot of input into emotional centers of the brain, like the amygdala, the cingulate cortex, which are like our emotional processing centers of the brain. And then those arrows end up going to areas of the brain that control things like movement or movement planning. And so, like, if I had to simplify that, I would say there's something that happens to people's brains that affects connectivity earlier in life and kind of sets the stage for this condition, with sort of aberrant inputs going into these emotional centers of the brain. And then a trigger, even a subconscious trigger that's cueing an emotional response, can ultimately result in a physical behavior. But those behaviors are being done involuntarily. So in our population that we see in our clinic, we see large percentage of patients reporting a history of trauma up in the 90 percentiles. About 60 to 75% of patients meet full criteria for PTSD. And ultimately, these aberrant connections lead to the patients having a heightened sense of arousal, autonomic nervous system, that fight or flight kind of on overdrive. And so it sort of affects the way that the patient presents out in the world. In terms of getting back to what do we do about this in the moment, well, making a call as to whether you're encountering a patient having an epileptic versus a non-epileptic or functional seizure can be really challenging. And I totally agree with that. I mean, I think even colleagues in my epilepsy department or neurologists have a hard time making this distinction, but it can be simplified if we know what to look for. But of course, people, you get influenced on the scene. You're worried about missing something. You're worried about the patient being status and under treating. I understand that completely. And then, like in this video, there's maybe even a patient's like family that's there saying, we don't know what's going on, help them. And so I think it can sometimes bias us in how aggressive we are in our treatment. And people like to practice this kind of better safe than sorry approach. But as I mentioned before, sometimes the sorry can mean that we've actually harmed the patient on accident trying to do the right thing. So I would just say, take a moment, take a beat, try to collect a history if possible. Hopefully there's someone there. If there's nobody there, we're using our best judgment. But ask yourself, what kind of seizure am I looking at? And could this be a functional seizure? And if so, how can you tell the difference? This is a really nice graphic that came out of a kind of an older publication at this point, 2011. That was comparing patients who had frontal lobe epilepsy, which tends to be these kind of hypermotor seizures coming from the frontal lobe, compared to functional seizures. And they were able to pick apart and kind of put into little diagnostic categories if the presenting symptom was common, rare, very rare. And I sort of pulled out the ones to the side here that I think are important to be looking for. So often when patients have, well, I'll start with epileptic seizures at the bottom. When patients are having an epileptic seizure, or specifically an epileptic convulsion, if it goes on for more than a minute or so, typically there tends to be some color change to the person because they're not breathing. So they might look a little dusky, they might look purple, they might look blue. They often have oral trauma, meaning that they bite their tongue or the inside of their cheek. Not all the time, but a lot of times they do. The interesting thing is that patients with functional seizures can also bite their tongue, but patients with epileptic seizures tend to bite the side, versus patients with functional seizures tend to bite the tip of their tongue. So that's maybe something to look for as well, but hard to see in the moment. They often, after the seizure is over, will have this really loud snoring, kind of gurgly type of breathing. We call those stertorous respirations for epileptic seizures. And then often, I put this in here because of our case, if you check somebody's pupils during an epileptic convulsion, typically they're not reactive. So moving to functional seizures, they tend to be more situational. They kind of have this gradual onset of like them feeling something coming, this sort of crescendos, decrescendos. Their eyes are typically closed, especially at the beginning of the seizure. They might have resistance to eyelid opening if you try to open the eyes, but again, this is an involuntary behavior. There is some undulating, kind of smoother body movements that might be kind of like kind of a looser tone versus an epileptic convulsion. They're very stiff, rigid, and have this like very fixed axis jerking. They may have one side of the body moving differently than the other. Their head might be shaking side to side or thrashing. They might be sobbing or crying during the episode. And then they tend to be more prolonged, so like more than 2 minutes, and may recover more quickly than somebody with an epileptic seizure. So you're never going to have the perfect scenario where they all fit very neatly, but I think trying to pick apart some of these things that would be very helpful. So if you encounter somebody who has their eyes closed, side to side head thrashing, undulating movements that seem asynchronous, they start and stop, very good chance you're looking at a non-epileptic or functional seizure. Okay. In terms of like, what else can we do to support our decision making? Well, I'm not exactly sure how often we're drawing labs in the field. Sometimes there's point of cares that are done on somebody en route. But there is some evidence for labs or to help with decision making. But I'm going to go through why a lot of them are not super helpful in the moment. So for lactate, point of care lactate actually can be pretty helpful if the level is more than 2.5, essentially. That's a pretty good indication that somebody's having an epileptic convulsion. Other types of smaller types of seizures may not have the significant elevation, but for convulsions, that's what a lot of these levels apply to. CK, which is a muscle breakdown product, sometimes people draw in the moment. However, CK peaks about 36 to 40 hours after a convulsive seizure, and you need to know somebody's baseline because people with neuromuscular conditions can have an elevated CK at baseline. So CK is not really very helpful. Prolactin was kind of in the literature for a while. We thought maybe prolactin was a good marker. It turns out if you draw a level within 20 minutes of a convulsive seizure and it's 2 times elevated their baseline, which we hardly ever know somebody's baseline prolactin, that can be helpful for distinguishing epileptic versus non. However, the false positive rate of this is very high, as some people have elevated prolactins if they're on antipsychotic medicines, if they have a pituitary tumor, and so high rates of false positivity as well. Ammonia, which is another protein breakdown product that sort of happens after somebody is having a prolonged convulsion, can also be elevated, but has to be drawn within the first 3 to 8 hours. So again, these time windows that make it difficult to make a decision in the moment. And then I'd be remiss if I didn't mention the Denver seizure score, given our geographic location. But essentially, patients who have epileptic convulsions very commonly have a metabolic acidosis with an elevated anion gap. And so they came up with a little equation that they used, essentially doing a metabolic acidosis calculation or anion gap calculation to come up with a seizure score of how likely it was that that person's seizure was epileptic. And turns out if you do this equation, put in their bicarb, their anion gap, and you get a score less than 0, it's a very low likelihood that it was epileptic. 0 to 20 moderate and greater than 20 high. So these are some things that I think can be helpful, or maybe they're even drawn en route and shown to a provider once you get there, but very limited and time windowed sorts of sets of labs that may not be super helpful right in the moment. But, I think have a role. So if we go back to our case, now that we're all experts, having just flashed this slide at you, we'll take a look at this video again and see if we can kind of pick apart the differences in the semiology or what it looks like.
We don't know he's gonna get out.
And so I'm going to try to talk over this a little bit. I'll turn the volume down. And so this one, as I mentioned in the case, this is going on for 45 minutes, so definitely prolonged more than 2 minutes. There's no evidence of cyanosis, so he looks like he's perfusing quite well. If anything, he's a little pale. No evidence of oral trauma, no saliva coming out of the mouth, no blood coming out of the mouth. As I mentioned, pupils were reactive during his convulsion. He does have this side-to-side head shaking, and you can see there's asynchronous movements of the hand. So the right hand is moving differently than the left hand. And so these are all things that are suggestive of a non-epileptic seizure. And then if I had to pick from that entire chart that I showed you, the only thing I was able to find that supports an epileptic seizure is that he has his eyes open, but can happen during a non-epileptic seizure as well. And so I think more than likely what happened in this case is that he has this known history of epilepsy. He's got his wife there that's freaking out. And I think that there was just some bias on scene of like, man, this guy's got epilepsy. We don't know what to do. He's been seizing for a long time. So let's treat him and treat him hard. But it turns out that was probably the wrong thing to do. So in this case, far more suggestions of a non-epileptic or functional seizure that maybe could have gone differently if people could have recognized those signs. So if I got back to the protocol and I had to get on a soapbox and say what maybe we could be doing differently, I would say there's some considerations that we should take into account. So first, when you're coming on scene, as it mentions, collect a brief history. Does universal seizure precautions or documentation. It says seizure history, onset, type of seizure, obtain medical history if possible. Now, again, if the patient's there by themselves, you're out of luck. But in this case, I think a history could have been obtained because this patient had a known diagnosis of both disorders. And if they had both, then you're like, oh man, what am I looking at here? So is the patient actively seizing? Let's follow this protocol. Yes or no? However, I would maybe add in, if yes, there is a line here that says if it's brief and self-limited, treatment's not necessary. I would probably add in that if it's non-epileptic in appearance as well, we could maybe add to that box that treatment would not be necessary if we're able to identify that. Considering the source, I think adding functional seizures to the consider the cause of seizures box, at least just as a possibility, should make it in there because, of course, that could happen in a high percentage of patients. And then document what you see in detail. So maybe if you're not the one who's comfortable making the call and you're like, you know what, I'm going to give this patient some Versed, that's fine. But document what you see. And maybe the next person who sees it may feel a bit more comfortable in saying, let's see what EMS said. And it says the seizure looked like the head thrashing side to side. Their eyes were closed. There was no sign of oral trauma. And that might help the next ER provider or somebody that you're turning this patient over to in their decision making. And so hopefully that sort of like down the line downstream effects of this patient's case where he got first the benzos and EMS, then he got the benzos and the ED, then he got intubated and sent to the ICU. Hopefully it breaks that chain of downstream effects. So documentation can be very powerful. And of course, if you end up saying, I don't know, or this looks epileptic to me, by all means, please follow seizure protocol. But I think just stopping and asking might potentially change behavior in some cases. So if I had to get back to kind of like this broad overview of what we should do about seizures given their source, I think, again, at the bottom here, if it's epileptic, doesn't really matter, focal generalized. If it's going on for too long, more than 5 minutes, you should be following protocol and considering reversible causes. If it's brief and self-limited, it's more supportive care, even in epileptic seizures. If it's non-epileptic and you ask yourself, okay, well, is this syncope? Is this something medical? That's just going to be treating the underlying cause. But if it's functional and you're able to feel pretty solid about, man, I'm really seeing lots of evidence here that this is not an epileptic seizure, really all that we're doing for patients is supportive care. We're letting it stop. We're giving them calming reassurance and not overreacting, which can actually harm the patient down the line. In terms of some best practice tips in the field, again, this is not wagging the finger at anybody, but this is just things that we hear from patients, unfortunately, because some people who have non-epileptic seizures may be in a full convulsion or maybe frozen, can't move, but they can still kind of hear what's going on. And so patients tell us that, I could hear them saying that I was faking it, that this was all in my head, and that can be very traumatizing to the patient who's already traumatized. Some people try to be a hero and show that they can stop the seizure by doing something painful to the patient. I wish that wasn't the case, but that happens quite often. They'll give them some like a sternal rub or a pinch or a supraorbital notch pressure or something to maybe try to break the seizure. However, that rarely works and usually just hurts the person. And then they wake up with bruises on themselves, and that's not a great way for anyone to wake up. If you determine that this is non-epileptic, I think also just completely ignoring the patient or neglecting to care from them is also potentially problematic. And then sometimes it's just really, again, just this calming reassurance that we can offer that can really make a big difference. And then sometimes people will laugh, they will make comments, especially for somebody who has a known condition that, oh, that's just Joe again, flopping around like a fish, he'll be fine in a couple minutes. Well, I think that's also, potentially harmful language to use, especially if the patient is somewhat conscious. So again, not wagging the finger. I don't think anybody in this call is guilty of any of those things, but it does happen, unfortunately. So I would say, do please treat each patient with respect. Try to triage the patient according to the severity of their presentation, attempt to ease their suffering and ensure they're safe, and then document what you see. So those are kind of my tips. To conclude, I know I'm going kind of fast, but I'm certainly not going to take the whole hour, so I'd love to have time for discussion. I'm going to show another case of a time in which, I thought it went really well. So this is another case of a patient that came to our clinic who gave permission for us to share her case and video. Is a 19-year-old non-binary individual. They have a history of functional seizures, anxiety, depression, Tourette syndrome, autism. And EMS was called to a shopping mall due to the patient having a prolonged seizure that was called by a witness. So upon EMS arrival, the patient was unresponsive, shaking with their eyes closed for about 10 minutes. So again, we're in that greater than 5 minutes category. So alarm bells of possibly needing to intervene. However, the patient was breathing spontaneously. There was no signs of trauma. They were able to successfully obtain a brief history from a supportive person and said, this patient has functional seizures. And they're like, oh, okay. Well, does that fit with what I'm seeing? These providers were able to make that assessment. They ended up not giving any medications. They provided some comforting reassurance to the person. The patient's father ended up on scene, who was the one taking the video that I'll show. And they were able to avoid an unnecessary ER evaluation and hospitalization. And so I'm going to show a quick clip of kind of what that looked like in the field.
Okay, how long has she been?
We've been on scene for probably about 10 to 15 minutes or so.
Okay.
She's been like this since we were with her. Been breathing okay, taking some good deep breaths, but just hasn't been responding to any of our questions at all. This is the state we've pretty much seen her in the entire time. So
okay.
She was laying on the floor. There was no fall. Apparently, she kind of.
All right, and so the physical features I can see, and I'll just kind of mute this and play it again, is that the person has their eyes closed. Again, no signs of cyanosis or trauma, as was reported by the provider. There's this kind of waxing and waning shaking that's happening. It sometimes goes fast, sometimes goes slow. The right hand and left hand are doing slightly different things. Again, it's been prolonged more than 10 minutes, so a lot of features of functional seizure that fits with this person's history. And then once they started coming around.
Your father's right next to us, okay?
Hi, I'm here.
Want us to help you get into that chair?
It's okay.
Takes a lot of energy to do that.
Yeah.
We just wanted to get you somewhere more comfortable.
You get up in that chair? We can lift you up. We can pick you up by your arms and your legs and put you in there. Yeah, let's take it nice and easy, okay?
Okay, so I mean, certainly not anything crazy, heroic that needs to be done. I mean, I think these gentlemen just did a really nice job of being supportive, not being disparaging, being very reassuring to the patient, offering physical assistance, talking in a calming manner. And really, that's all it takes. I know that's overly simplistic, but if you're able to make this difference on scene, we can imagine how much differently this could have gone if the first video was not this cool, calm, and collected reaction. If it was, we're giving them Versed and we're sending them to the local ER, it could have gone very differently. But the fact that they were able to identify this, I think, is a win and what we should be striving for in the field. And then ultimately, the seizure stopped on its own. They were able to get the person in the chair and go about their day. So this is what I would call when it goes right. So that's all the slides that I have for you. I know that was really quick, and we have an hour and a half, so I certainly want to open it up for some discussion. But this is just kind of a plug for our program here. We have a really talented group of individuals that we work with at the university. I'm sure some of you are interested in some of the work that we do, but we see patients who have non-epileptic or functional seizures. We also see patients with functional movement disorders. Dr. Strom and myself sort of lead the clinic, and then we have a talented group of therapists, behavioral health providers, physical therapists, psychologists, nurse navigators, and a case manager to sort of help these patients. Our primary intervention is that we do group psychotherapy for these patients, which can be done virtually or in person. And then for patients with physical therapy needs, we have trained individuals who are offering that as well. It's a 12-week course where the patients see us once a week for therapy. They learn a lot about what the condition is and how we can make it better. And then patients that we see here are often given a seizure action plan. And so especially for somebody with a known diagnosis of functional seizures, they may have something on them, like a bracelet. They may have a paper. They may have something in their phone that says that they have non-epileptic seizures, because that's what we sort of tell them to do, and try to provide some information just so they're not getting into these sticky situations with first responders. And so that's all I have for you guys. And I'd love to just kind of open it up for some questions, and thank you for your attention.
There are a couple questions in the chat. First, do functional seizures ever present with the post-ictal period?
Yes, they do. As I mentioned in the slides there, they tend to come around a little quicker. However, I do have patients that report to me that after a functional seizure, they're like wiped out for the whole day. And so they feel very fatigued. Depending on the type of seizure that they have, it still might be very physically demanding. So they might feel sore. They might just need to lie down. But they're not going to have that like super confused, trouble breathing, snoring breathing that we see after an epileptic convulsion. So oftentimes it's more just this kind of, I don't feel good and I might need to take a nap after a functional seizure, versus kind of the more extreme end of things after a prolonged epileptic convulsion.
Awesome. And then, is there any evidence for acute non-pharmaceutical treatments to terminate the functional seizures?
I wonder what they mean by that. So acute non-pharmaceutical treatments. No. And so I don't know what that would be like.
Do you want to give some examples, Justin? Are you thinking like some maneuvers or something?
I just more meant like in the moment to like try and terminate the seizure, other than giving like Versed if you're suspecting that it could be a non or functional seizure.
Yeah. So again, I think the things that I see people do are like sternal rubs, are like some sort of pressure, something to sort of like break them out of it. However, that typically doesn't work and just causes harm. I see some people sometimes do this like drop arm test to see if they like move their arm out of the way or if it just lands on their face. Again, that's not really super helpful in the moment. Oftentimes what I ask patients in clinic, I say, is there anything that people can do for you like during a seizure that would be comforting or helpful? And oftentimes they say, no, just get me into a safe spot. It's going to stop eventually. Some calming reassurance, some verbal reassurance, or maybe like a gentle touch on my shoulder would be helpful. Some people say that they feel really hot when they have these. And so maybe like a cool compress to their like neck or face is sometimes helpful. But honestly, like the minimal amounts of things that you can do is what's typically recommended. Is that helpful?
Yeah, that makes sense. Thank you.
Yeah. And so, I think, when we see these patients in clinic, sometimes people prefer to be left alone. Sometimes people, do want some physical support. And so if anyone is there with them, they probably know what's helpful for them because they've seen them before. I'm seeing another message come in the chat. Are you seeing any EEG changes from baseline in functional seizures? So I didn't go through the whole diagnostic workup. That's a separate talk that I give because I don't know that it's as relevant to what to do in the field. However, great question. The typical workup for somebody with non-epileptic seizures is they get the same workup as someone with epilepsy does. They get an MRI of their brain typically, they get an EEG. If the EEG is normal and they're still having episodes, then typically they do get admitted for prolonged EEG monitoring or an EEG at home. And when they have their seizure, if there are epileptic changes or electrical changes in the brain at the same time they're having symptoms, then the diagnosis is epilepsy. It's not functional. However, if they're having their full episode of shaking, loss of consciousness, something that we would think would cause a change on EEG, and we don't see that, that is the documented, definitive way to actually make this diagnosis. And so we don't always get lucky and capture them on EEG. So we rely often heavily on videos. And so clinical diagnostic criteria tells us that if somebody's had a normal EEG and a video or a witnessed interaction of somebody having a seizure, we can make a clinical diagnosis of probable non-epileptic seizures, which sometimes is the best that we can do. And so, no, there should not be any changes on the EEG at all. It should be a normal EEG while they're having their functional seizure. However, sometimes we do see some people that have these like very tiny episodes, like they just have a twitch in their finger, or they feel a strange sensation, or they like briefly like have a lapse in attention for less than a second. And so even if those were epileptic seizures, we wouldn't expect those to have changes on EEG. So there is some nuance when it comes to reading an EEG, that if it's a clinical change you would expect to see an EEG change for, and we don't see it, that's when we can make the definitive diagnosis. For patients who have both conditions, even if they also have epilepsy, you still should not see an EEG change during a non-epileptic seizure. Okay, another question is, with epileptic, patients can vomit. Non-epileptic have nausea and vomiting as well, or cause choking. So I guess the question is like, sometimes airways can be compromised for epileptic seizures. Does that happen for non-epileptics as well? Oftentimes they're not vomiting during the episode, usually before or after. However, yeah, that can happen, I think, in rare cases in both conditions, in both epileptic and non-epileptic. And so I think still practicing best practice guidelines, the first step on that seizure diagram is ABCs. And so if there's any vomit or saliva or something obstructing an airway, you should be clearing that with suction if you have it, or getting them on their side, which is sort of universal protocols. It should not cause prolonged apnea. So if you're seeing that color change, cyanosis, it's more than likely that you're looking at an epileptic seizure. And I think airway takes priority regardless of the source. But when I'm counseling patients and their families in the clinic on what to do, because oftentimes their family is calling 911, I say, these are typically self-limited. If the patient is not going to, like, their brain is not going to fry because it's not an electric seizure, they're not going to stop breathing forever. So if you can manage this at home, just giving some supportive assistance, that's typically what we try to strive for. But I think, triaging the situation of any oral compromise, whether that's vomit or something else, should be a priority, the first thing that you do on scene.
Any other questions from anyone? And I'll put the QR code for CEs and link in the chat while you guys are thinking of more questions.
Do you have any questions, Dr. Farkas?
No, I don't. And, I think I briefly touch on this with my agencies. A couple months ago, we did a talk on a seizure patient and kind of talked about functional logical disorder, but obviously it was 2 slides. It was not as intense. And, we've all been the ER doc who has thought a patient was in status and intubated. We've all done it. And so it's very helpful to kind of hear this.
Yeah, no, it's super common, unfortunately, and that's why we give these talks to, try to at least plant the seed as to this as a possibility. During one of these talks that we gave to AMR, they actually were able to change their regional seizure protocol to include functional seizures in the consider the source box. And honestly, even if that doesn't change management, I still think it's a win if people are at least crossing their mind, like, what type of seizure am I looking at? And so if that's all that comes out of this, and you picked up on a couple of things of like, oh, side to side head movements, closed eyes. I'll remember that. I mean, I think that's a win for a first responder, just to plant the seed. But of course, I think the overarching message is if you're unsure, please err on the side of caution. However, you saw the drastically different outcomes for these two different patient cases, where one ended up in the ICU and one just ended up going home in a wheelchair. So yeah, very different. And I hope that planting the seed can make a difference in time.
A lot of these folks are with agencies for which I do medical direction, write the protocols, and so you've definitely given me something to think about.
That's great. I would love to follow up with you in some regard, as we have sort of consulted for some of these regional entities. Oh, another question came in. It looked like in both videos, most movement was noticed in the upper body. Is that most common? I would say yes, actually. It tends to be like torso, upper body. You do hear of this like very classic thing that patients can do, which is like, I can never say this word properly, but epizotonic posturing, which is like severe back arching. So like if they're on a stretcher or gurney, like they're like coming off of this gurney, like just their lower extremities and upper back are touching. And so that's a very classic finding seen in non-epileptic seizures, not in epilepsy. And then there's also pelvic thrusting that people talk about, sort of like more pelvic movements up and down, can also be a very common finding for non-epileptic seizures that we don't see in epileptic patients. But I would say if I showed you 100 videos of non-epileptic seizure, it does tend to be more of this upper body sort of tremulousness and movements. Yeah, like in tetanus. And so there's like these classic sort of like pictures of these like things that look like demonic sort of possession, where the patients are like really arched off the bed. They can sort of present like that. So if you see that and it's not due to tetanus, which is pretty uncommon these days, it's more than likely a non-epileptic seizure. Okay.
Wonderful. Thank you so much. You guys should have the link and then or the QR code, whatever your preference is for your CEs. We'll stick around for a couple minutes if anyone's any questions. Otherwise, you guys are good to go. Thank you again.
Yeah, thank you. I would like to say I apologize for the brevity, but I'm sure most people appreciate it.
Yeah, to dinner time.
All right.
Awesome. Have a good evening, everyone.
Thank you. Thank you for having me. Bye-bye.
Bye-bye.